First, we have Lori Engler-Todd. Lori, since 2020, has worked as a director providing support to Canada's Chief Science Advisor, Dr. Mona Nemer, who many of you know, particularly on her COVID-19 expert panel, as well as her task force on post-COVID-19 condition. This was published almost 2 years ago now, but Lori is here today to provide an update on some of the work that they have done since. So I will invite Lori to the stage.
Just going to get myself sorted so everybody can hear me. Got a clicker. Okay, so good afternoon, everyone. And I just want to say it's a pleasure to be here with you all at the second Canadian Symposium on Long COVID. I was at the one in Montreal last year, and it's great to be here again. So it's been interesting and informative already, the sessions, I think, and moving, especially referring to the art that surrounds us. I think it's really impactful. And I think it was a great idea to do, and thank everybody for participating. So thanks for the introduction, Doug. My name is Lori Engler-Todd, and I work in the Office of the Chief Science Advisor, Dr. Mona Nemer. And Dr. Nemer's been Canada's Chief Science Advisor since 2017, and I'm pleased to say she was appointed for another 3 years just last week. That's great. I feel that way too. She sends her warm wishes to all of you, and she really does wish that she could participate here today, but you have me. As part of her mandate, the Chief Science Advisor provides scientific advice so that science informs public policy and so that policymakers have the evidence they need to make good decisions. So the report I'm going to be talking about today was developed in that spirit of providing advice. So in the next 10 minutes, maybe 15, I'll provide an overview that may entice you to take a look at the new Chief Science Advisor report on PCC that's going to be going live very soon. So it's ready, it's just in web coding, so it might be live tomorrow or maybe early next week. And so I'm going to go through information in the report, including scientific updates, persistent knowledge gaps. I'll touch a bit on the progress made since the last report that was released last year and recommendations, and I'll wrap up with some concluding remarks. And just as a bit of background, Chief Science Advisor established an expert panel on COVID-19 where we discussed all topics COVID related, and then specifically a task force on PCC was stood up in July to develop a roadmap that provides a framework to manage PCC. And there's task force members in the room here, and Doug Ross is one of them, and some of the experts that were engaged, as well as some of the people with lived experience. And I would note here that the WHO, the World Health Organization definition of PCC was adopted at the time by the task force, recognizing definitional variability. So based on the deliberations of the PCC task force, and available scientific evidence, a series of reports have been developed, as shown on the slide. And I'm going to be talking about the new report, which has the same title as this session. So lots has happened since the first report was published and the pre-report, and the SARS-CoV-2 virus has evolved from alpha to delta to different types of Omicron now. So in the next slides, I'm going to go through each of these bullets on the slides and provide a bit more detail, and then I'll move on to persistent gaps. So to start, data is still showing that a significant number of people are affected with PCC. And I'll start with the Statistics Canada Canadian COVID-19 Antibody and Health Survey, which is a mouthful, had a follow-up questionnaire released in December of 2023, and that data showed about 1 in 5 Canadians that had been infected with the SARS-CoV-2 virus reported long-term symptoms. That represents about 11% of the adult population, or 3.5 million people, and about half of them were still experiencing symptoms. And that's a significant number of people. I would say that the data across the world is similar, and one US prevalence study recently done showed a similar range of 2 to 11% prevalence of PCC or long COVID in adults. So in terms of risk and burden, data is showing a long risk horizon of about 2 to 3 years post-infection. And there is quite a bit of data showing PCC increases the risk of, the risk of PCC increases with reinfection. And we've known for a while that immunity wanes over time. And to show the impact, I was looking at some of the posters, which are really interesting on workplace impact in the room, that within the same StatsCan survey, about 100,000 people were unable to return to work and 600,000 missed work or school for an average of 24 days. I think I saw one poster said it's more like 43 days. So you're going to see some variability, but the point is there is a significant impact here. And a recent US study on long COVID disability showed a prevalence of disabling long COVID of 1.5%. That's 4 million people. So, I mean, I think these numbers really, to me, they hit me hard. It's not an insignificant thing. So if I move on to care and treatment, I think everyone in the room knows this, that there's no easy test to diagnose PCC still, and there's access to care issues and wait lists, and I think it would depend on the local environment. And the data is showing still a continued risk of chronic illness. And so as Dr. Hotez mentioned this morning, a SARS-CoV-2 infection increases the risk of chronic disease, including cardiovascular disease, diabetes, neurologic impairment, rheumatic and autoimmune conditions. And there's evidence of associated cognitive deficits like brain fog and trouble concentrating, et cetera. And perhaps that results from immune-mediated brain injury. And I'm cheating a bit here because it was just a recent study put out about that, but all to say is this report, that the recent studies are really reinforcing what we saw before and what we're still seeing. And I know that there was a workshop on mechanistic pathways earlier today, and that really just shows there's an intense area of study right now, and the understanding the how is essential for treatment. So we need to understand those metabolic pathways and biochemical causes that can lead to PCC so that new treatments can be developed. So, and evidence is also showing that it could be multiple different pathways stemming from a dysfunctional response to the virus, including immune exhaustion. So in terms of persistent gaps, we know that the definitional issues remain, and those definitional issues affect all aspects of PCC management, care, research, policy. And we're learning more, but we don't know enough yet about pathogenesis. And we lack data on subpopulations, including First Nations, Métis, and Inuit, as well as children, youth, and older adults. And we do need these standardized clinical practice guidelines so that healthcare providers can consistently treat adults, children, and youth. And while I've mentioned some data on socioeconomic impact, I mean, there's still little recent data, and we need a broader understanding of what PCC does from a work perspective, a financial perspective, and a family dynamic perspective, that sort of thing, and more, and what to do as well, like effective interventions and return to work policies. So we also still have gaps in PCC prevention, including public messaging. In terms of progress, I mean, we're seeing progress in the literature of our collective knowledge and action. I'm not going to go through this whole list because I could be here for a while, but I think really importantly that recent evidence demonstrates that vaccination reduces the risk of developing PCC by about 40%, and that the risk has declined from about 10% of unvaccinated individuals earlier in the pandemic to about 3.5% among vaccinated people during Omicron. And I'm quoting some of the research from Dr. Ziad Al-Ali, and I just also want to mention that the data points in here are referenced in the report. So even though a reduction is being seen scientifically, that's still a large number of people. And it's postulated that the reduction is driven by vaccination and less so by changes in the evolution of the SARS-CoV-2 virus itself. And I'll just also add on the slide that when we looked at the clinicaltrials.gov website, about 60 clinical trials were listed, and the majority were for treatment for things like antivirals and anti-inflammatories, and some to characterize PCC and risk factors. And in addition, the US RECOVER has more than 40 pathobiology studies underway. That was as of June. So definitely progress is being made, and notably the long COVID web is in place now, and that wasn't in place when the PCC task force was deliberating. But even with all this progress, it's clear more effort is needed. So this is where it brings me to the last PCC report. So this one is really an update of the full report that was released last March, and priorities are aligned with the 3-point framework that was developed by the task force. And I just want to mention that the recommendations in this report are aimed at government and the public sector, of course, but also for not-for-profit, private sector employers and insurers and other organizations as relevant. And this is just to show that all the priority recommendations are aligned with a common vision to reduce PCC and its impacts. So overall, priority actions, really they're unchanged from the same presentation that I gave last year. So I'm not going to spend too long on here, but on this slide, I can go into a bit more detail about some specific priority actions that are recommended. And I think that'll resonate with people in the room that we really do need acknowledgement that PCC continues to be a risk. And we need to emphasize that PCC prevention through evidence-based actions, things like wearing a mask and keeping your distance or not going to work when sick, and highlight protective effects of vaccination and indoor air quality. And on indoor air, a real potential benefit could be realized across respiratory infections with improved air quality, especially in crowded places like schools. And we need to accelerate this excellent foundational work on PCC pathogenesis for effective treatments. And we still need to develop and harmonize the PCC terms and definitions for adults and children. And I'll note that the National Academies of Science and Engineering Medicine just came out with a new definition. So there's still work to be done to come together. And we urgently need interim clinical practice guidelines, and experts could be brought together involved in providing care to help develop those. And we need innovation in healthcare models and evaluate them to support resilient healthcare systems. And again, it's more than PCC that could help with. It could help with other post-infection chronic conditions. So to conclude, infection and reinfection are risks for acute and long-term chronic illness. And as you know, individuals with PCC require care, support, and treatment now. Even though all this research is going on, it's really important to have things in place. The prevention of PCC, hence infection prevention through different means, really is essential. And Canada should participate in large-scale international networks. And I know a lot of that's already going on with Angela Chung's work, but there's also links that could be made with Recover and other broader initiatives around the world, and perhaps a development of a long horizon global strategy for PCC and other post-infection conditions. And just on the definition, once we have a universal definition, we really do have to ensure its widespread adoption. And I'll make this last broader statement that what we've learned from the COVID-19 pandemic is that there is a burden of chronic infection from a large scale number of people being affected. So that when we see this in pandemics, we should be looking at the long-term impacts, and that should be integral to emergency response and preparedness. So at this slide, I just want to acknowledge and thank everyone in the room and online for participating, as well as task force members and guest experts, as well as individuals with lived experience who, you've all been working really hard together and challenging each other to help manage this condition and help people who are suffering from its effects. So thank you very much for all of that. I'm not sure if we have time for questions or.
I'm not sure if that's a yes or.
Yes, please go ahead.
Thanks so much for your presentation. It's really important that we have our federal government engaged on this. I just wanted to ask about the prevention aspect of things. You mentioned indoor air quality and you mentioned vaccinations, which are great. I fully support both. I'm glad you didn't mention hand washing because it is kind of useless. Good for other things, but not for this particular problem. And I just find it a bit ironic in a room full of maskers that you haven't mentioned masks. There are situations like crowded indoor spaces like we exist in now, and in particular hospital spaces, long-term care spaces, where masking is essential for prevention. And I'm just wondering if that's just was an oversight in the slides, or is that something you guys have decided not to advocate for?
Oh no, apologies for that oversight. I would put masking under evidence-based interventions for prevention, and I think there's evidence for that, especially in crowded places. Thanks.
Great, thanks for that. I'll just go over to the question first in person, and then we'll do an online question. Go ahead.
Thank you for this. It tells us the government's taking it seriously, and scientists know it's real, so this really matters. I saw your numbers and your estimates. Based on the Cedron report, that's a big pan-Canadian report, with a huge database, 80 emergency departments involved, and they came up with a number that's 38% of people who caught COVID went on to have long COVID, and it stayed pretty consistent for 18 months. And sitting beside someone from StatsCan on the plane, turns out they used this questionnaire that we patient partners came up with for the Cedron. And their number, now years later when there've been repeat infections, is 50% of the population has long COVID by the WHO criteria. What is your office going to do? Will you look at those and perhaps change your estimates? Do you have enough sway to tell the government polio paralyzed 7% of the people who caught it, and with good rehab, a lot of them went back to their lives again? We still have the institutes that were built for polio. What have we got for COVID? I know we need research into causes. We need research into the underlying mechanism and treatments, but this has to be a simultaneous building of the airplane as it's taking off, I've been told. So there's that. And the other is, I grew up in the era of participation that the government sponsored, and it was really effective. We ended up way fitter than a 60-year-old Swede. Any chance they can do that? Can they team up with CSIS, who is now putting out tweets saying, don't believe everything you read about vaccines, it's foreign actors, and to paraphrase, they're seeking to seed fear, distrust, and lies. So, you know, there's lots of things that can be done around public awareness, and now we have social media, which is very powerful. What is the role of the Office of the Science Advisor of Canada, and what can they do officially, and what can they use their influence to do? Because this is a way bigger problem than most people realize.
There's a lot in, I'm just trying to process and sort of unpack some of it. I'm just like, I totally agree with you about participation. I really loved the little badges. For the data, yeah, I agree. The estimates are different depending on the definition that was used in terms of the prevalence. I think we have better data now that Statistics Canada, if I remember correctly, have had like 3 different cycles in Canada. So early on, we didn't have any data at all, and I completely concur that there's variability within them. The fact that people are vaccinated, have different doses of vaccinations, different timing of vaccinations, different types of vaccinations, and some people aren't vaccinated. So with Dr. Ziad Al-Ali, and I'm not an expert, so I'm just trying to unpack a little bit of the questions that you're saying, that you're asking. So I think that's all gonna affect the numbers that you're gonna come up with. As for the role of the Chief Science Advisor, I mean, Dr. Nemer, and again, she's the expert, and so are the expert panel members. So she's there, and she can play a convening role, which she does, and that's one of the things she did when she established the COVID-19 expert panel as well as the task force. And she can speak to Canadians, and she's our official spokes. So, putting out a report with these recommendations should help, but she's there to provide science-based advice. We don't monitor what others are doing, or we don't have like an auditing, policing function, but we're there to encourage and bring the scientific evidence to the forefront. So hopefully that we can do that bit with the report as well. Was there another question in there that I missed?
Less a question, more a request, and not just to the Office of the Chief Science Advisor of Canada, but also to the research in this room. Please don't use post-COVID condition. Don't use PCC. It's long COVID. It's a patient-coined term. And using post-COVID condition instead subliminally sends the message that you're not going to center the patients and value the lived experience, which, as was addressed in the conversations earlier, in the speeches earlier, is a good way to get off on the wrong track and to waste a lot of resources. So my message to all those listening is it's long COVID. It's a term that was coined by patients. This is a patient-led community. Patients drive the research. Patients should always be centered in the research. So it's a little bit disrespectful to use post-COVID condition and exclusively PCC. And that doesn't even come up as what's associated on a Google search. If you put PCC in, long COVID has awareness. So for the sake of getting the information out to the general population, long COVID. Be consistent, always long COVID. It's long COVID web for a reason. It's the long COVID symposium for a reason. Don't use post-COVID condition, please. Always out of respect for the patient community, it's long COVID. Thank you.
And thank you. I really don't know how to, if I can respond to that, if you would like one. I mean, it really came from the WHO definition, but I do recognize, as I mentioned, that the National Academies of Science and Engineering Medicine in the States has used long COVID, and I do think things will progress. So I think we should stay tuned.